Welcome to Optic Surgeon, the ophthalmology podcast.
Glad to be here.
Today, we're doing a focused exploration, specifically for ophthalmology residents and final year MBBS students. The topic, glare.
Yes.
Glare.
Very common complaint.
Exactly. Think about the last time you encountered a patient, complaining of bothersome glare, especially maybe at night.
It happens a lot.
It's such a common issue, and really understanding its intricacies is crucial for effective diagnosis and management in ophthalmology.
Absolutely.
So our mission in this deep dive is to equip you with the essential knowledge about glare, following a structured approach that hopefully will be directly applicable to your learning and clinical practice.
Let's jump right in. Maybe start with a case.
Good idea. Let's set the scene.
Okay. Imagine this. A 50-year-old man, he's a previous radial keratotomy patient, maybe had RK, say 20 years ago.
Okay.
He presents with a pretty significant complaint. Glare. And also starbursts, especially around lights at night.
Right. The classic nighttime symptoms.
Exactly. And he also mentions, almost as an aside, that his vision has gradually worsened over the past decade. Needs stronger glasses now, distance and near.
That sounds like a really typical scenario where understanding glare is just paramount, isn't it?
It really is. It brings together several potential issues.
So let's break it down. At its core, what exactly are we talking about when we say glare? What is it?
Well, glare is essentially a visual symptom, a disturbance.
Okay.
It happens when bright light sources cause scattering of light within the eye. And that scattering reduces contrast, making it difficult to see clearly.
So it's the scattering that's the key mechanism.
Precisely. And it can manifest in various ways. You might hear patients talk about difficulty seeing in bright sunlight, or seeing halos or those starbursts around lights at night, like in our case example.
Right.
And sometimes just reduced visual acuity overall, but only in certain lighting conditions.
And it can be a signpost pointing towards different underlying conditions.
Absolutely. It can be a symptom of various underlying ocular conditions and, importantly, previous surgeries, just like with our RK patient.
Okay, so let's dig into those causes. What are the main mechanisms that lead to this light scattering? You mentioned the RK patient.
Right. So number one is probably corneal irregularities, like in that RK patient.
How does the RK specifically cause it?
Well, that previous corneal surgery alters the normally smooth refractive surface of the cornea. Those radial incisions, they can cause the periphery of the cornea to steepen over time while the center flattens.
Oh.
And this can potentially result in nighttime glare and starbursts because essentially you've created a kind of multifocal optical system that wasn't intended.
Makes sense. Are there other corneal issues besides surgery?
Definitely. Corneal dystrophies, for example. Something like epithelial basement membrane dystrophy. You might know it as map-dot fingerprint dystrophy. That can also cause irregular astigmatism and consequently glare. Basically anything that disrupts that smooth front surface.
Okay. What about things inside the eye, beyond the cornea itself?
Yes, moving deeper. Cataracts. Hugely common cause.
The lens clouding up.
Exactly. Opacification of a natural lens causes light to scatter as it passes through. Patients often notice this most, especially in bright light conditions.
Okay, cataracts. What else?
Then there's dry eye. Seems simple, but an unstable tear film leads to irregularities right there on the corneal surface.
Even momentarily.
Even momentarily, yes. And that contributes to light scatter and glare. It's often overlooked.
Good point. And post-cataract surgery, can glare still be an issue?
It can, yes. Sometimes issues with the intraocular lens, the IOL itself, maybe reflections within the lens material, or if the IOL isn't perfectly aligned.
Okay.
These can sometimes cause glare symptoms after the surgery.
You mentioned nighttime glare being common. Does pupil size play into this?
It absolutely does. Think about it. At night, our pupils naturally get larger, they dilate.
Right, to let more light in.
Correct. But that larger pupil can then expose more of any existing irregular corneal surface, like from RK or more of the lens opacities in a cataract.
So it exacerbates the underlying problem.
Precisely. That's why symptoms are often worse in low light. And one more important one, related to cataract surgery again, posterior capsular opacification, or PCO.
Ah, the after cataract.
That's the one. Clouding of the lens capsule behind the implant after cataract surgery. That membrane getting hazy can definitely cause glare too.
Okay, quite a few potential culprits there. So a patient presents with glare. How do we approach the diagnosis systematically? What's the workup?
First step always is a thorough history. You really need to drill down.
What specific questions are key?
You need to ask about the onset. When did it start? Duration. And critically, the specific lighting conditions where the glare is most bothersome. Is it day, night, oncoming headlights?
Details matter.
They really do. And always ask about previous ocular surgeries, like our RK example, any trauma, or any underlying medical conditions. Think diabetes, for instance, which can be associated with conditions causing glare, like cataracts.
Got it. History first, then the examination.
Then the exam. A careful slit lamp examination is absolutely essential. You need to look closely at the cornea for any irregularities, signs of dryness, scarring, and then assess the lens for opacities, for cataracts, or signs of PCO if they're post-op. Don't forget to evaluate the tear film quality and measure the breakup time.
And you mentioned corneal topography earlier.
Yes, corneal topography can be incredibly helpful. I'd say almost vital in patients with a history of refractive surgery, like RK, or if you suspect any kind of corneal ectasia or irregularity.
Because it maps the surface.
Exactly. It gives you that detailed map of the corneal curvature, showing you where the problems might be.
What about dilation?
Pupil dilation is important too. It allows for a much more detailed examination of the entire lens, not just the central part, and also the posterior segment. Helps you properly stage cataracts or spot PCO.
And refraction, obviously.
Of course. Refraction is necessary to determine the patient's best corrected visual acuity and identify any refractive errors, especially astigmatism, that might be contributing to or even be the main cause of the glare.
And you had a note about RK and refraction.
Yes. An important point for post-RK eyes, specifically. Be aware that the keratometric readings, the Ks you measure for astigmatism from the cornea, might not perfectly match the refractive findings what the patient actually needs in their glasses.
Why is that?
Because the altered corneal curvature after RK creates a more complex optical system. The front and back surfaces might induce different effects. So rely on the refraction, but understand why the Ks might look different.
Good pearl. Okay, besides these main causes, what else should be on our differential diagnosis list? Things that might mimic glare.
Well, you should always consider simple, uncorrected refractive error, especially astigmatism, as we mentioned. Also, very early cataract formation, sometimes glare is the very first symptom before the vision chart acuity drops.
Right.
Dry eye syndrome, definitely keep that high on the list. And in specific post-surgical cases, like after LASIK, you might think about diffuse lamellar keratitis, DLK, or sands of the Sahara.
Okay.
But that typically presents with other inflammatory signs, maybe pain or significant haze, not usually just glare.
Okay, that makes sense. So we've done the history, the exam, we have our differentials. Let's talk workup and management, especially tying it back to our RK patient.
Right. So for our RK patient with glare, the workup really emphasizes looking for those corneal irregularities. Use different slit lamp illumination techniques, sclerotic scatter, retroillumination.
Really try to highlight the issues.
Exactly. And again, corneal topography is crucial here. It quantifies the irregularities.
And once we've identified the cause, how do we manage it? Let's break it down by cause.
Okay. Management strategies really depend entirely on that underlying cause.
So if it is corneal irregularities like post-RK or a dystrophy,
For those, spectacles with anti-reflective coatings can sometimes help just by reducing surface reflections.
a simple step?
A simple first step. Contact lenses can be more effective, especially rigid gas permeable lenses, RGPs.
How do they help?
They essentially create a new, smooth optical surface over the irregular cornea, masking the irregularities and often improving vision and reducing glare quite significantly.
What about surgery for these cases?
In some situations, further surgical intervention might be considered, but honestly, it's complex, especially in post-RK eyes. It's usually last resort. For something like epithelial basement membrane dystrophy, treatment focuses more on managing recurrent corneal erosions if they happen lots of lubrication, maybe bandage contact lenses.
Okay. What if cataracts are clearly the issue?
That's more straightforward. Cataract surgery with IOL implantation is the definitive treatment.
And IOL choice matters.
It can. The choice of IOL can sometimes be tailored, discussing with the patient options that might minimize potential post-op glare, although no lens is perfect.
Makes sense. And if dry eye is the culprit?
Manage the dry eye aggressively. Artificial tears, often unpreserved ones, are better to avoid preservative toxicity, which could worsen the surface.
Right.
Puntal plugs to keep tears around longer, maybe prescription dry eye drops. Improving the tear film stability can really reduce glare.
And for that PCO after cataract surgery?
For PCO, the treatment is usually an NDD.YAG laser capsulotomy.
Okay.
It's a very quick, effective in-office laser procedure.
Clears the visual axis.
Exactly. Creates an opening in that cloudy capsule, clears the visual axis, and usually resolves the PCO-induced glare very well.
Finally, what if it's mostly down to refractive error?
Then the key is ensuring optimal correction. Make sure their glasses or contact lens prescription is spot on, especially any astigmatism correction.
Any specific lens recommendation?
For patients with high refractive errors, high-index lens materials can be beneficial. They make the lenses thinner and lighter, which can also potentially reduce unwanted reflections or distortions that might contribute to glare perception.
And general advice for any glare patient?
Yes, regardless of the cause, advise patients on practical strategies. Using good quality sunglasses in bright light is key. Maybe advise against driving directly towards the sunset or using visor at night. Avoiding direct viewing of bright light sources when possible, especially at night.
Simple, practical tips. Great. This has been a really thorough breakdown. If you had to pick one high-yield pearl from all this, especially for our residents and final year students grappling with these glare cases, what would it be?
Okay, here's where it gets really interesting, and it ties back to our case. When a patient with a history of refractive surgery, like that RK case, comes in with new or worsening glare, remember this: corneal topography is your best friend.
Emphasizing that again.
Absolutely. It provides that detailed map of the corneal surface. It reveals the extent, the nature of the irregularities contributing to their symptoms. It's really crucial for guiding your management approach in these complex eyes.
And the other point about RK.
And also, just to reiterate, be aware that in these post-refractive surgery eyes, your refractive findings, the glasses prescription, might not always correlate perfectly with the keratometry readings from the cornea.
Because of the complex optics.
Exactly. The altered corneal shape creates a more complex optical system. So trust your refractor, but understand why the numbers might look a bit different. That understanding is key.
Excellent, Pearl. Really practical advice.
Hope it helps.
Well, that's a wrap on this focused deep dive into glare for ophthalmology residents and final year MBBS students.
We covered quite a bit.
We certainly did. We've gone through the key aspects from, understanding the mechanisms behind glare to practical approaches in diagnosis and management.
The key is putting it all together.
That's it. Remember to always correlate your findings, the topography, the exam with a thorough patient history. Context is everything.
Absolutely.
Stay focused, keep learning, and of course, subscribe to Optic Surgeon for more essential insights in ophthalmology.
Keep asking questions.